Welcome everyone to CHEAR seminar. We are in December. We are in the final push. We have, I think, 3 more seminars. I actually can't remember what next week's is. Who is it? Do you remember?
It's
No,
me,
she's
Sarah.
19th. It's who?
It's me. This is Joy.
Oh, great. Joyce. It's Joyce. So we'll have Joyce for seminar next week. And then the week after, Erin Carlton will be talking about pediatric costs after, I believe, critical care visits or admissions. So, but today we have Dr. Courtney Streur, who is an assistant professor in pediatric urology and also, of course, in CHEAR. She earned her MD at the University of Missouri Columbia School of Medicine, and then trained in general urology at University of Alabama, Birmingham, and then completed her pediatric urology fellowship at U of M. She also obtained a master's in health and healthcare research from U of M to get her training in health services research. Courtney also has a K award from NICHD. And is that what you'll be telling us about today? Awesome. Great. Thanks. Thanks for joining us, Courtney.
Yeah, thanks for having me. So it's great to be here. We've had a lot of people on medical leave in my division, and so I missed out. So it's good to be here. So I'll be talking to you today about my K award, and I thought I'd like for a second just back up because I know it's kind of a mixed group and I haven't met everyone. But I am a pediatric urologist, and my focus in my practice is taking care of people with physical disabilities. So people with physical disabilities, especially like abnormalities of the spine or how the muscles work, often have issues with their bladder and bowels. So both like in being continent, and also like my biggest job is to protect their kidneys, keep them from getting UTIs, keep them up so the kidneys working well, as well as their bowels. And so for those reasons, they like follow with urologists typically lifelong. So that's a population I'll be talking about today. So there we go. So the work that I'm going to talk about today has been funded by my K award, as well as a award from OB-GYN by sponsors, as well as a sponsored award from the Department of Urology. So the transition to adulthood is really difficult for all of us, but it's made far more difficult if you also have a physical disability. There's a lot of research out there to show that people have, they show up to their appointments less, they come to the emergency room more in kind of like crisis, and they have decreased health outcomes or lower worse health outcomes during that time. And so when I started into the research world, I knew I wanted to do something to help with this. And I do run a transition clinic now, but I wanted to do something on the research side to help with this. And so the first thing I was kind of interested in is I felt I had met several mothers who had spina bifida, which is one of the physical disabilities. And I was interested, there was like really nothing out there about their pregnancy outcomes. And they said that they had a hard time finding information during pregnancy. So I was like, oh, this would be a great thing to look at. So my earliest work was in looking at pregnancy, and we found that people with spina bifida, as well as really other physical disabilities, the rates of their deliveries of babies was significantly increasing. But more importantly, I found that over 25% of their pregnancies were happening when they were still being followed in pediatric clinics. And so that inspired my next line of work, which I presented at CHEAR a long time ago. But long story short, in talking to these women about what was going on, I found that, no one was telling them about their sexual health. They assumed that my bladder doesn't work, my bowels don't work, my uterus probably also doesn't work, or things are just probably different, and I am sure I can't get pregnant. And so as I started talking to women in research, women in pregnancy, I heard so many stories of, unintended pregnancies, or, we unfortunately live in a society where there's this huge bias that people with disabilities are asexual. And so we as providers treat them as asexual, society treats them as asexual. And so if someone, there's a woman who talked about if someone comes and treats you like a sexual being, that you will accept how they treat you, no matter how they're treating you, just to be seen as sexual. And so there's plenty of research out there to show that women with physical disabilities have lower use of preventative care, lower use of contraception if they're sexually active, high rates of unintended pregnancies. And as I talked to my patients, I started getting several women with unintended pregnancies. One woman who didn't even know she was having sex because no one taught her what sex was, and she catheterizes her bladder and didn't realize that was also where her vagina was. And just, yeah, they also have, women with physical disabilities also have 4 times the risk of sexual abuse. But even, I don't want to say more importantly, but as important is that, you know, when you're not educated about your sexual health, you can't really make decisions for what you would like. And so they had a lot of just like goals and unmet needs that were never discussed by providers. So that, in talking to the women, both my patients and with research, they decided what they wanted was something like online where they could go and learn about their sexual and reproductive health. And they preferred the online format. And so that's kind of what I went out to do with my K award. But in doing so, I really wanted to have a different approach. So I think a lot of like various interventions to help with the transition to adulthood don't have the greatest outcomes. And I think it's partly because they're made by providers like myself who, like, to me, the bladder and the bowels are everything. To someone else, the brain is everything, you know, like, so you have, it's very fragmented and people are not seeing the bigger picture. And so I wanted to make sure that, you know, even though this was about sexual and reproductive health, but it was really about more like adolescent wellness, like taking the whole picture into account. I think the other problem that we have with all the transition readiness programs that are out there is that we have this conception that people will turn 18 and they will be adults. They will take on all their adult responsibilities. And for these people, this is often with like increased medical needs. Maybe they catheterize their bladder, maybe they have to be on enema programs. They have to navigate the medical system, which is real easy to do. They have to deal with all the societal biases of providers, people at school, at work. Many have executive functioning limitations, so planning, issues with planning, which obviously makes this easier. Some also have a cognitive disability. And so we're asking them to do all of this by the time they turn 18 to be success. And I think the reality is, this is my family. My mom is currently in town. She is watching my kids. She will be doing some of my laundry today and putting it in my closet, and she's cooking me dinner. The reality is, like, we are paying too much attention to the child and wanting the child to be completely independent, and we are isolating the parents, I think. And parents are often their children's big support. I am 40 and my mom is still my biggest support. And so we really have to like take into consideration how we can support the parents in supporting the children. Obviously, we want the children to be as independent as possible, but reality is many of these parents need to also learn how to support their child. So the whole picture. So this is kind of like an overview of the work I've done and I'm going to be doing. So up top is like the more strict research stuff. So I started by, as I talked about, like interviewing adolescents and women with spina bifida to learn about their experiences related to sexual health. And then I recently completed interviews of parents of adolescents with physical disability to learn about their perceptions of their child's adolescence and what they want from this intervention. At the same time, I also interviewed college students with physical disabilities to figure out, you know, I'm always pushing my patients to go to college to get jobs, but I don't really know what that experience is like. And then kind of the next phase will be doing some work with both adolescents and parents to compare their desires for the website and that kind of thing. And all in the meantime, I've been developing a website that I'll show you. So to start off, I'm going to talk about the work that I've done interviewing parents. And so this is a qualitative study that I did doing one-on-one interviews using mostly grounded theory for evaluation. And we talked to 21 mothers. About half of them had spina bifida, about half had cerebral palsy. And we're going to go through, there's kind of like 4 major themes or papers that came or are coming from this, and I'll go through each of them. So one of the first things we asked about was their experience getting periods and managing their periods. I know that that's an issue, but I realized like I have no idea what to tell my patients besides periods can be an issue. And so in talking to them, we came up with these names, and I'll go through each of them. So the first thing that we learned is however prepared the parents were for periods coming was how well they could prepare their daughters. So some parents were aware, and I should back up and say that early puberty or precocious puberty is common in this population, having periods around like 7, 8. And so some parents, whether they were like involved in the disability community, this one was like a special ed teacher herself, were aware of that and were able to prepare their daughters. Some had no idea, and their daughters thought they were dying one day when they got their period. And then both parents, as well as the daughters, had like often pretty strong but variable emotional responses to the periods coming. So, you know, if there's a cognitive disability, then often they view their periods as a sickness. It makes sense. You bleed for however many days. They perceive that as a sickness. But interestingly, even if they didn't have a cognitive disability, this is a population where they are often sick. And so there is, even if they knew that it was a period, they just almost like felt like periods are abnormal or a sickness. And then moms who are primarily taking care of this, they are already doing a lot. And so sometimes like adding a period on, adding something else to manage is a real burden to them. But at the same time, if their daughters are like really independent, they're already cathing and doing things for themselves, for them adding periods on is also feeling a burden.
What proportion are going on puberty blockade?
Yeah, that's a great question. I don't think we have the answer to that, although I guess you could use some, maybe I can do some more traditional HSR work and find that out. But we don't fully know the answer to that. We know like a lot of people go to the adolescent gynecologist to ask for that, but I can't give you percentages. That would be, let's see. And some parents felt like their daughters had like just a typical period, you know, sometimes light, sometimes just kind of regular. But some parents felt like their daughters had like really significant side effects or symptoms associated with their period. So moodiness was described a whole lot. That was very common. And then they also, especially if they are CHEAR users, would experience like gushes, especially with transfers, like just gushes of blood that often led to very embarrassing situations. Period products are not accessible. So if you think about using a pad, using a tampon, that requires a lot of dexterity. And so, and even like there's great period underwear now, which was viewed for most as the most accessible method, except if you had to change that period underwear during the day. It requires you like to totally undress and also to have pretty good dexterity. And so many parents and daughters really struggled with period management. And as a result, like had to, even if they were otherwise totally independent with toileting and that kind of thing, they often had to rely on someone to help with the period products. And a lot of people also use pull-ups, which they found are not made for periods. So related to that, menstrual management while at school was a huge issue. So this periods come at a time when emotionally girls and developmentally, girls just want more privacy. And so there are some people who had male parapros or during COVID, especially as that one who had the lunch lady helping, like there was just a shortage of people to help with periods. And that was very distressing for the girls. And then some parents just didn't want anyone else to help out. But no matter what, even if the daughter was also already getting help for, you know, toileting, bladder, bowel stuff, they felt like periods were just different and a much bigger burden. Parents were hoping that healthcare providers could be more helpful. So like, you know, providing anticipatory guidance about what to expect, the fact that periods can come early, what products to use and what's out there. But at the same time, many experience like whether they wanted, as you're talking about, like period suppression options or not, they found resistance from healthcare providers. So some felt like birth control was pushed on their daughters and they didn't want it and they wanted to be respected for that decision. And conversely, some mothers really wanted birth control for their daughters who had a lot of symptoms, and some healthcare providers were not supportive of that. So in conclusion, menarche menstrual management is certainly impacted by having a disability. and products are not accessible. And just in general, we as healthcare providers, schools need to do a better job supporting these adolescents.
Courtney, can I ask you a question? And if you're gonna get.
Go.
When thinking about healthcare providers engaging with parents and adolescents, like, is there any guidance or thought to where the onus of responsibility sits on what healthcare provider and who should be?
Yeah, so that's a huge problem. And I kind of like actually, when I first, before I got into this, I remember having this, she's still one of my, she's a patient like that, but this woman in my clinic, young woman who was talking about her boyfriend drove her and he was in the waiting room. And I remember thinking like, oh, I wonder if I should like ask her about like birth control, STIs, but like I'm a urologist and I haven't thought about this. And like surely someone else is, like surely if she is sexually active, like her pediatrician or her gynecologist is talking to her about that. I actually talked to her about it a lot now because no one was. And the thing is like, so many times these, especially in adolescence, these children don't regularly go to their PCPs, or I feel like some PCPs, like they don't know. Some do a great job and some like feel like, I don't know. I'm sure you do a wonderful job. Yes.
That's not the issue.
Yeah.
I was gonna finish your thought.
Okay. But you know, so much of their care is with specialists. And so we as urology have taken responsibility, but we're not necessarily doing a good job. It's something we're talking about more, but we're not doing a good job. But I can tell you, like I've referred people, not here. Here our gynecologists are excellent, but they've gone to their home gynecologist to talk about birth control, and they talk about menstrual suppression. They don't talk about anything else besides this menstrual suppression. So that's part of the issue. That's also why I'm like just going to straight to consumer. Yeah.
I think an important issue in this specialist generalist interface is that whether it be explicit or implicit, many children are also given the message that they don't need a primary care physician because they're seeing the specialist and they're seeing the specialist on a regular basis. And so they develop this longitudinal relationship with their subspecialist or specialist and don't then, the need for a primary care physician is either devalued by the specialty care. Oh, you don't need to see them, I'm taking care of you. Or they're seeing so many specialists that there's no time for the primary care provider. So
and
that's
especially, and I think like especially with adult specialists, they don't necessarily feel comfortable taking care of some of these patients with congenital onset.
Not talking about adults right now, just talking about kids. And then so it raises 2 points, which you may or may not do right now, is that if you have not involved a primary care physician as a partner in this effort, I think it would be a good idea to do so. And then secondly, you may have already done this, but you spoke about obstetrics gynecology. And there actually are people here, and you may already work with them in pediatric gen who actually focus on children with disabilities. And maybe if they're not partners in what you're doing, might be, and if you're not connected with them, I'm happy to help.
I work very closely. Monica Rosen comes to our,
Good.
and it used to be Lisa Quinn comes to our transition clinic.
Great.
Awesome. Yeah, thanks.
But she's engaged in actually research with Peach on this, you know, the issue of inequity in treatment of children with chronic illness in spina bifida.
Yeah.
So in fairness though, I think oftentimes primary care pediatricians also want to punt responsibilities to the specialist because they have that longitudinal relationship. I'm not saying this is right, but I mean, you know, sometimes it's parental preference, family preference.
Sometimes it's parental preference.
It's like, I'll come to you maybe for my shots, right?
Oh,
You know, and then all my other issues, but so there becomes this kind of like squirrely, like who exactly is responsible for sexual health, counseling, and it ought to be, I mean, it's probably not one right answer for all patients. And I think that makes it really difficult. And this is not your population specifically, is any population. I think
Right.
this happens.
Right, any
This is
specialist.
Any children with medical
Yeah.
complexity in general.
Yeah.
This is a real problem.
Very much. So a few things, if you know of any pediatric, I do all the spine motion clinics, I run peds transition. When I go to Sparrow, it's like a CMS clinic and we have a pediatrician and it's awesome. But MOT is not structured to.
CMDS.
Yes.
Okay.
MOT is not structured to support transition clinics, and I can't, so, but if you know of any pediatrician who wants to come anyway, I'm trying to get med peds to come to to the transition clinic. Med peds provider.
No, because of the way that, like the ACO structure.
Nice, good, quick
Yeah.
question then. So from pediatric pulmonary, we like cystic fibrosis, vent, like there's a lot of these issues about transition and there's different models for how to do it and where so is your transition clinic a one-time, like last stop before you transition, or is it a period of time?
It's a period, yeah,
Okay,
so we
and-
start ideally at 16, and then, everyone's different, but it's like around age 22, but the thing is, like, it's, we are allowed, it's a transition in adults, so some people like the multidisciplinary care, and so they want to stay in that clinic, and so that's fine, and they, I can tell you, my colleague doesn't feel as comfortable talking about sexual health, and he also doesn't address the bowels, and so I often continue like at least popping in to see patients.
This is your colleague in urology?
Yeah.
Okay.
Yeah.
I mean, one thing that whether it's a generalist or a specialist, nobody feels competent in talking about sexuality in a positive way. I mean, at best, you're gonna get discussions about sexually transmitted infections, coercion, but nothing about being supportive. I mean, individuals like this are locked out of, there's a literature that in schools, they're not getting the same education as their peers. So before we say, well, they should turn to the medical home, the question is a medical home going to propagate more biases? It could be more harmful than helpful. And even if you look at mental health providers who should feel comfortable in this area, there are surveys showing they feel totally inadequate. I mean, it's just we feel good talking about sexuality as a problem. We don't feel good talking about it as something which is part of our essence.
Yeah. No healthcare provider feels comfortable talking about it. I get asked actually to talk about how to talk to people about sexual health, and it's ironic because like I didn't start it till I don't know the last 5-7 years, and I don't necessarily always feel comfortable. Or I with practice it becomes more comfortable, but at the same time I don't think I present at academic meetings, I talk to providers about talking to their patients, but I don't actually think it's gonna happen. This is recorded. I think that the best way is to go to the parents who are invested and have them talk to their daughters. I'll get to this later, but like they're the ones who think that it's important. They're the ones who understand their daughters. They're the ones who understand how their daughter learns and what their daughter needs to know. And so I think either having them, like parents, talk to their daughters or use our intervention with their daughters, or letting their daughters use it on their own, I think is the answer.
When you interviewed the parents, did the topic of guilt, shame that the parents experience, I mean, as a potential barrier to their daughters moving forward, being overprotective, not wanting them to be harmed?
They worried about them being naive and being vulnerable due to being naive. But this is qualitative, so people had to sign up to do this. But most of them thought it was far more important than it was for their other children who don't have a disability. Interestingly, there's Tracy, her last name starts with a K, who have done this very similar work in the CF population. I don't know if you know.
Yes, so I was just gonna say, give you my anecdote. So I know, so the home vent population is much more similar to this. And I know that I've been caught flat-footed when a teenage patient has asked me questions and it was like, oh yeah, there's this whole other side of you that I really haven't been dealing with. And this issue of, I have the longitudinal relationship with you because I see you in vet clinic 4 times a year and it's too much of a pain in the neck for you to physically get to your PCP. So you go to your PCP for vaccines and when you break your arm, but not for, or need stitches or something, but not for, your routine care. So I have been.
Bones, I just want to.
No, well, I have been absolutely guilty on that side. I would say the counter example is the Cystic Fibrosis Foundation or CF community, where there's been a lot of emphasis on transition, and it's really a process that starts around age 12, and there's a formal program from the Cystic Fibrosis Foundation about, there's like education modules and different milestones of education. And because fertility is a big issue in CF, both for the boys and the girls, like that's part of the educational program. And you do run into the problem that different individuals feel, and providers feel more or less comfortable having those conversations. But there's a group in Boston, which I think is who you're talking about, that created a website with an incredible library of materials about sexual health, reproduction. How does your lung health change as you go through puberty, nutritional health, all, amazingly in-depth, detailed knowledge specific to this population. And so now it's easy to sort of do the anticipatory guidance as kids are hitting puberty to say, even if it's just like, here's the website, like when you feel ready, here's something to go to, takes a lot of the burden off the individual providers. And it's been a real asset to the CF community. So I'm like applauding you for tackling this.
There's a woman who reached out to me at one point and she's like, I think our work is similar. And I actually just yesterday emailed her again because I came across one of her publications and I was like, look, we're like step and step. Although I think if her website is up, my website is not up. So, but it's interesting. The difference I would say between that makes this population especially challenging can be the cognitive disabilities that can be associated with it. All right, so and I love this discussion. So I'll just kind of fly through stuff, and if you want to talk, I don't have to get through everything. You can read the papers when they come out. All right, so the next question that we had is so we know that a lot of these adolescents don't meet their social milestones, or at least not on time. They have some delays, but we don't really know why and what that lived experience looks like. And so that was another question that we asked parents about, was their daughter's social experiences. So one of the things that we found is that puberty is a time where the daughters really become more self-aware and therefore more self-aware of their differences. So even, I shouldn't say even, but girls who have no visible disability, you'd meet them and never know, suddenly felt like everyone could see it. And that was really hard for their self-confidence. Or at the same time, you could look at them and no one would ever know, but they're capping and they have to do an hour-long enema program at night, and they may be late for school and they didn't feel like people understood what they were going through. At the same time, on the opposite extreme, for those, especially with a cognitive disability, they would go through the physical maturation of puberty, but not the same emotional maturation as their peers. And so while they could have played, with their peers without a disability well when they were young, suddenly they are growing up and, as this woman said, they're no longer talking about Sesame Street. So parents describe a lot of barriers to friendships or social relationships in general. So they felt like some of their children, because of all the medical stuff that they went through, just felt safer at home and didn't want to do like the sleepovers or camp or those types of things. Also, there's just far less opportunities when you have a disability, especially if you have to go to PT after school or those kinds of things. You couldn't do this, like for some people, can't always do the sports that other people are involved in. So it was hard to have opportunities. And if you have a cognitive disability, there's really not really opportunities to like get away from parents and develop kind of quote unquote normal peer relationships. So facilitators, so people have mixed views, especially on like special ed. Some people found that a good situation for their child where they felt more comfortable, but at the same time, other people found that like their children were kind of like a mismatch for their classes, but that was a facilitator for some. And then a lot of people who had older siblings, or older sibling really like proactively would help them find friends. So regarding romantic relationships, most people were interested, except like for this one young woman who is brilliant and has an awesome personality, but worried about leaking at night, so having fecal incontinence. And then there were some people, especially with cognitive disabilities, who are big, kind of like boy crazy, as they described. But there were far fewer opportunities that people had, again, like partly just like not opportunities to be away from parents and around their peers and kind of develop those kind of social norms. Yeah, so, but some did have some. And then a lot of parents talked, and of course this is from the parents' perspective, but they felt that their relationship with their daughter compared to their siblings or their own relationship with their parent really was very stable throughout adolescence, which is consistent with some of the known literature. Grayson is one. And part of that is just like everything that they've been through, and they've been through a lot of surgeries as a young age, still going through a lot of surgeries, but also they may just need their parents in kind of a different way, but they don't have as much of that like parent-child conflict that normally happens in adolescence. But nonetheless, they still really wanted to be independent. And so Alexa kept coming up, like that was something that a lot of girls, even if they had significant physical or cognitive disabilities, they could boss Alexa around. They really like that. I'm trying to figure out a way to like incorporate Alexa into the website. And they also really appreciated providers who would talk, even if their daughter had a significant cognitive disability, who would talk directly to their daughters. So certainly adolescence is a big time of change. But some of the reasons I think that why these adolescents have a delay in their milestone is, besides just some cognitive disabilities for some, is becoming more self-aware, the medical trauma that they've been to, difficulty relating to other people if they don't have the same disability as yours, and then less opportunity for interactions. So I think like this is one thing where I as a provider, when I saying like, you need to do your bowel program every night, or you need to wear a catheter overnight, I really need to like think about and address like, oh, but if you want to do a summer party, it's okay to not wear, have a catheter overnight, or just kind of being creative. So the next area that we looked at was, I tried to figure out what parents are worried about during adolescence. So I feel like sometimes there's a mismatch of what we as providers push and address in these transition clinics and what parents are actually worried about. And so I'll go over all of them. So one thing that they're really worried about are kind of the new health concerns that their daughters develop, especially mental health. Mental depression and anxiety is a big issue for these adolescents. And then the actual transition to the adult healthcare, where especially for those with a cognitive disability, they go from like having child life and like a fun children's hospital to a very stale. I'd love for there to be an adult life specialist one day, but that's not the truth yet. They cared a lot about their daughters gaining independence in their life skills. So a lot of it was more around like activities of daily living, although certainly managing their own healthcare. But they found there was just a lot of barriers. It was really hard for some parents to teach their children new skills. And then for some people, like they really had a hard time motivating their child to take over certain things, whether like there's some cognitive issues there, or they couldn't figure out what was the motivation or lack of motivation. As we talked about the social issues, that was a big concern for parents. And other research has shown that this really makes parents feel like a failure if their children struggle socially. They also had a lot of like interest in what a future romantic relationship would be like. and what dating would be like, and especially what sex would be like. A lot of parents like brought up, they're like, my child doesn't feel, I don't know what to tell her about sex, but I know it's not gonna be normal. And yeah, they saw it as a very normal adult experience that they wanted for their child. And then they were very concerned about their child being feeling empowered, feeling self-confident, and being able to like go out and do the things that they want to do in the world. But this was a big struggle. Many of these girls had issues with self-confidence. And then there's just a lot of problems in our society that they have to consider. So we talked about the risk of abuse, but even things that I didn't think about, like schools. So our schools have so many programs in place to support these adolescents, which is awesome, but that doesn't necessarily mean that people really get it. And so as this mom talked about, like, they don't understand, like they really need a bathroom pass for whenever they can get it, or like they may be late and they may miss days, more days than a typical student, and like it has to be okay. And then they also have to think about like, okay, so first off, it is really hard to work and find a job if you also need disability. They make it, very hard. But if you are someone who like wants to go and get a job but also has like medical needs, you have to really consider what insurance you can get, what that insurance will cover. And then this mom was very worried about like, I know my child is going to be late again because their bowel program runs over the next morning, or have to miss for doctor's appointments. And what if they get fired for those reasons and then lose their insurance? So some mothers really like care for their child and have hopes and dreams for their child that are very holistic. But what they worry about is where those dreams intersect with the reality of our society and the structures that we have, as well as just lived reality with a disability. And so the last thing we asked parents about was their preferences for the sex ed in general, experience with sex ed, and then preferences for the website. By the way, the like random art on here is all for the website. So one of the biggest barriers that they mentioned to having sexual reproductive health conversations was they're like not knowing disability specific information, again, like what sex would be like, or they're not knowing how to like tailor like basic sex ed to someone with a cognitive disability. But nonetheless, they like usually talk to their child about peeing and pooping all the time and just their body in general. And so they felt much more comfortable talking to them about their sexual health as well. They felt like their daughters were much more open to talking to them about it because, again, they've been through so much together, and they understood their body more. And they felt like it was important, just like they recognize that things are different with the disability, and they wanted their daughter to learn those things. So they felt that sex ed was very important, again, so that their daughter could make their own decisions and be informed about what to expect. And then in terms of the intervention, they went through a lot of different preferences, but some of the big ones, one is they wanted it to be flexible. So they wanted it to be flexible, so it could be tailored to the girls' both physical disability as well as there's any cognitive disability. They felt like, what the CDC or whatever recommends for like this age you learn this age you learn this, it needs a lot more flexibility than that. And then they also were really opposed to anything that pushed social beliefs. So we know out there's a lot of controversy and like war, I guess, about like certain social things going on. And it's not that they didn't want to explain those things to their child.
Can you be specific?
Oh yeah, so gender was a big one that came up. So gender identity.
I mean, look at the orange one right there.
Yeah,
That's a big one.
So yeah, that was masturbation. And so it's not that for some people with cognitive disabilities, they said that like their child is just not going to understand that. And I can say from some of my patients, like they don't really know. I mean, I can relate it to my young children. They don't understand what makes a girl and a boy. It's just like you're a girl or a boy. And so the gray is not. But then for other people, it's more of a values thing. And it's not that they didn't want their children to learn about them, but they wanted to be the ones teaching, so they could share their values. All right, so overall, they were very in favor of sexual and reproductive health education, though. I'm gonna try to fly through this a little bit. And so I interviewed people with college students with physical disabilities, and I'm gonna fly through this. We're just kind of like completing the analysis for it, so I'll give you some high level themes. So they found that that colleges actually were not very accessible. So even if they, like a lot of these old buildings, it's hard to make accessible. Maybe the way that you could get in was be like to the loading dock next to the dumpster. You know, colleges have hills, it's mainly a pedestrian kind of thing. So it was hard to find accessible. And then like everyone we talked to, the handicap bathroom was broken. Like all these different campuses or other people use it. They found that some professors were very supportive, but again, some didn't really get it. And this concept of like equality over equity, and you know, if I make exceptions for you, then I have to make exceptions for everyone. And even like professors who are very accommodating, nonetheless, unlike in grade school, they would have to continuously remind the professor, like, oh, remember I need extra time, or you know, things like that. They really had to consider their disability in career planning. So while grade schools were the most accommodating for people with disabilities, college less accommodating, jobs really don't need to be all that accommodating. And so suddenly they went from like being told they could do anything all their life to realizing like, yeah, I actually have to think about what would be feasible for me. And also what barriers I'm willing to fight. But it was also a huge time of personal growth for many. It was a time that they were like around other people with disabilities for the first time. And I had to like develop this whole concept of like disability pride. At the same time, some people didn't want to be like pegged as like, oh, you have a disability, therefore you can only hang out with people with disabilities. And then they just kind of took more ownership, and took more ownership for their own health. And it had just a lot more social opportunities. So that kind of delayed social growth that we often see. Yeah, so I'm just gonna go on to the next. So all the while we have been working on developing this website. So one of the first things that I did was work with a disability artist to develop the characters that we are using on the website. And so we went through 2 rounds of feedback from stakeholders. The first was during a conference that's made for like parents, people with, it's for spina bifida specific, healthcare providers. So it's like a whole mix of people. I put up the images at the end of a talk and like had people just give feedback, come up to me afterwards with feedback. And some things that we learned from this first like round of options was that they wanted a diversity of bodies, and they wanted an inclusion of someone without a visible physical disability. And it's kind of like a wider range of people. So then we used social media to get feedback on like these next 2 options. And some of the feedback that we heard is like they really resonated with the people without an assistive device, as well as like other individual ones. They absolutely hated the handlebars on the wheelchair, and they didn't like that it wasn't like depicted more accurately. Like they didn't want an abstract wheelchair. They wanted it, the assistive devices to be pretty accurate. But they loved that they looked happy, especially because the media tends to portray people with disabilities negatively. And overall, they just wanted like more people so that they could, it would give everyone a chance to relate to someone in the picture. And someone also mentioned they wanted hobbies. So this is a final picture that the artist came up with. And we're using much of this art in our, on the website, and then also in the films. So these are 4 of the films that she's made so far about like what is puberty, what is the period, how to manage a period, and what private parts are. And also I went to the World Congress on Spina Bifida, and I made there's a lot of people with spina bifida who are their parents. This was a parent, every kind of provider. So again, thinking holistically and also thinking about what I can use in the future, like neurosurgeon, PM&R, or like social work, all kinds of different people sit down with me. We recorded, it was 60 videos that we recorded in 2 days. And this is kind of an example of, this is a mom and daughter. The daughter has spina bifida. And then also attended some like adaptive sports practices and interviewed the athletes, and then also sat down with all the adolescent gynecologists and the Center for Independent Living Care as well, and recorded some more. So this is the mock-up of the website. It's going to launch hopefully this month, if not early next. It was named Ability for Life, again with feedback from stakeholders. This is the landing page. There'll be a page for learners, so that'll be the adolescents, a page for parents, and a page for community. For right now, it'll be like a curated kind of Q&A. And this is just like the first page. Yeah, and then this is the landing page for the adolescents. And as you can see, the sex ed stuff will be kind of divided up by stage, so that there'll be like a questionnaire to figure out what stage you should start with. Parents will also have the option to like select their own videos that they want to watch, make their own video library for their daughters. And then we'll also have like a section that's just like inspirational stories I collected from all over. So the next steps, I'm working on developing, actually we're piloting a best worst scaling study to compare the concerns about parents and with their adolescents. We'll be testing the website. And then I hope to develop some content specific for schools. One of the people who's helping me create the website is an occupational therapist with early on who goes into schools. And so like learning how to do accommodations, teaching how to cap, that kind of stuff. It'd be great to like eventually get the sex ed stuff in there as well, but there's a lot of barriers to getting anything sex ed in school. And then like expanding the content to like, you know, general adolescent wellness more for boys, and then assessing barriers, facilitators, and low uptake groups. So spina bifida especially impacts the Hispanic population disproportionately, and they tend to be low uptakers of sex ed interventions. And so figuring out like beyond just translating everything into Spanish, like what we can do to increase buy-in with them. So these are so many people that I have helped, but my research managers, Jennifer Latham Robinson is the artist, Monica Rosen, who we discussed. I have an adolescent and parent advisory board. And then, yeah, I'm working with many people at making the website. So I'm very thankful.
I love seeing Rebecca up there.
Have you worked with her? Oh, awesome. Yeah, she's great. I have only recently, like I think since September, started working with her, but she is like so organized and very good at making things look great. I mean, actually, she probably could have, I mean, I know she would have done this much better than I did. Yeah.
Courtney, I just want to say that like that's amazing. Like what you've built is really remarkable, and I think it's like so nice that it like reflects empowerment and ability, and you know, and like good design for this population, right? So I think like really like wonderful work. It's so nice to see where you started and where you've come with this. It's really amazing.
That means a whole lot, especially coming from you. So I appreciate that. By the way, you're kind of like a voice in the sky. I'm sure. Just escape that. Okay.
Hey, Courtney, can I just say one thing? So,
Yeah.
you know, there's the impact of research question that everybody brings up, the idea of, you know, funding and all these elements that people really get giddy about. But ultimately, you know, this is the kind of work that I think sort of uplifts, you know, the voice of the voiceless, you know, the disenfranchised, the marginalized in society. So, I mean, kudos to you. This is, you know, I was listening to this on Zoom. I was like, no, I need to go up, because this is the kind of work that I really deeply appreciate. You know, for me, this is more than an RCT, you know, in terms of impact. You know, so thank you for doing this. And I know it's a lot of work. I love qualitative studies, you know, because they really get to the heart of the matter, you know, almost the how and why, rather than just the quantitative, sometimes superficial overview of things. So thank you. This is, and from a surgical, you know, specialist to doing so phenomenal collaborative work that is impactful. And yeah, so thank you, Courtney.
Well, thank you, and thank you, and you have helped take care of some of my patients. So I appreciate it so many, yeah.
So I agree with everything you said. The rubber meets the road in whether or not people use it, right? Because we can create the greatest things in the world. And people have, but then the funding runs out. And then we don't, number one, sometimes we don't know if anyone uses it. And then B, we don't know if they're using it the next year. I'm sure you've been thinking about that because you've put so much time and effort into this and it's so well done. What's going on in your head about that? And
Yeah,
plans?
I definitely think about that. So I'm taking, as part of my KA, I'm learning about implementation. And so I just finished the implementation science 1 with thinking about like how do you implement something like this or and disseminate as well. And so that's where like developing content for schools comes in, I think is important, and for parents. And I do intend to like kind of there be ongoing content. So that community page will be a Q&A where I hope to get people to ask questions, kind of poll everyone, get responses, and then be able to kind of put them all together and give answers. And there'll probably be some use of social media by someone who can use it better than I can. But yeah, so that's one of the ideas. I think too, like I like going straight to the low adopters and figuring out how do I make this something that is acceptable to you and tailor it to individual needs of certain groups will be important. But I do work with like advocacy groups too, who have kind of asked for this and informed this as well. And I ultimately think, which I hadn't really thought about that, there's someone, I'm blanking on his name, but he helps with like innovations that researchers come up with and helps you like with copywriting stuff, but also thinking about the future. And as I've talked to him, I do think that this hopefully will be like, someone will take it and from me eventually. Yeah, I feel like, I don't know if anyone watches, listens to How I Built This by Guy Raz on NPR, but he talks about people who start companies and their goal is always for someone else to buy it. That's kind of like what my hope is eventually. I'm not ready yet, but eventually like for it to be adopted into like a spine association or adopted in a United States Cerebral, someone
to take it over
yeah,
and be in charge of it.
Yeah.
It was along the lines of my question is, what does the like community-based organization space look like around this? Or is that a little bit difficult to think of because it's, you know, cross conditions, you know?
That's an interesting question. So so my patients mainly have spina bifida. So that's like what I've mostly been involved in, but I'm getting more and more in the transition role with CP, and there's just so much overlap there. And so spina bifida is less common, very united. CP, there's like a lot of different organizations that kind of compete, which has been interesting. So it kind of depends. But it's interesting, I've brought it up a few times and they don't really understand, but I think there's so many needs that each of them have that they're focused on that I think there would be a benefit from trying to unite or have a united front for certain conditions.
We have in gynecology, the sexual health program, where you have certified sex health counselors. To what extent do you reach out to them? How many of these patients you're speaking about are engaged with them? Because that's where some of the expertise lies.
Yeah, so there is, if I'm understanding what you're referring to, there is, she's in social work, but she has been trained with a training to teach people with cognitive disabilities sexual health.
No, I'm just thinking of the sexual health program in general. They certify people from around the country. They have a program here, it's long-standing. They work with the adult patients, survivors of cancer, where reproductive anatomy is not what it was before.
Yeah, yeah. I guess I'm less familiar, I know a lot of people who have like, are in that realm. I don't know if their actual program, so maybe something I should ask about, yeah.
Sure. You know, just I learned a lot. I spoke to you about that documentary, Crib Camp.
Yeah.
It's a horrible name. It's on Netflix, 2020 documentary. It really talks about the disabilities rights movement. But what's so touching, what I found the most touching aspect of it was how the sexuality of these individuals were ignored. They went to this camp and it was an awakening for them, that they could have crushes, they could fall in love, they could experiment. I recommend it to anyone. And actually, one of the attendees at the camp was sort of a leader in the disabilities rights movement in the US, and she just recently passed away.
It's remarkable to think how young the ADA is.
Yeah.
Courtney, thank you. I'm sure we have a couple minutes at the end, but I wanted to bring to everyone's attention, because I know it's almost 10. I will advocate for Courtney going up for promotion at some point soon and needing these sorts of reviews to submit. So if you could please, if you're online, there is a link, and if you're here, there's a QR code to give feedback for Courtney for her talk. So thanks for a great presentation, Courtney.
I appreciate
That was
the
excellent.
input.
Yeah.